block grant funds. And without further ado, I'd like to introduce Patricia Deegan, PhD. She is the founder of Pat Deegan and Associates. For over 30 years, Pat has been a thought leader and disruptive innovator in the field of behavioral health and recovery. Pat founded a company run by and for people in recovery. The mission is to safeguard human dignity by bringing individual voice and choice to the center of the clinical care team. Toward this end, she developed the Pat Deegan recovery approach that includes the award-winning Common Ground software, as well as medication empowerment, certified personal medicine coaching, and the online recovery library, and the Common Grounds Academy for peers and practitioners, including the Hearing Distressing Voices simulation. Since 2009, Pat has worked as a consultant, helping to develop and evolve the On Track New York model for coordinated specialty care teams for young people experiencing early psychosis. Pat is an activist in the disability rights movement and has lived her own journey of recovery after being diagnosed with schizophrenia as a teenager. She has held a number of academic appointments, has numerous publications, and has carried a message of hope and recovery to audiences around the world. Pat received her doctorate in clinical psychology from Duquesne University. So I will hand it over to Pat, and thank you very much for attending.
Thank you very much, Rebecca. Say hello to everybody. It's good to see you. I'm beaming in from Massachusetts. Today, I'm here in my home office, and I'm going to take a moment to set up the share. Our talk today is titled Widening the Lens, Working with People Who Experience Oppression. And I'd like to begin, as always, by thanking each of you for the work that you do. I feel it's very important, especially in these times where things are getting very difficult for a whole lot of people, that we're here, that we're faithful to the work. And not only are we faithful to the work, but we're looking to improve our skills, to improve our inclusiveness and our ability to reach people who are experiencing all different sorts of oppression and prejudice on an interpersonal level, and to make our programs and to make our services places that welcome you no matter who you are. And this is very important. And I think sometimes in behavioral health, we don't hear it enough, that the work we do is really important. And that's why we get the big paychecks. That part's not so accurate. But in any case, it matters. And thank you for what you do. I'm going to begin by telling you a bit of a personal story, but that's okay. Way back in the 1990s, and I know some of you weren't even born then, but it definitely was illegal for gay and lesbian couples to get married in my state of Massachusetts. So Deborah, my life partner, and I, we just went ahead and married ourselves down in Provincetown on Cape Cod. And it was a really beautiful ceremony. And not long after, I was asked to give a talk in Lisbon, Portugal. So we decided to go on a honeymoon to beautiful Madeira, which is an island. It's actually off the coast of Africa. It's part of Portugal. So on the way to Lisbon, we stopped off for a honeymoon at Madeira Island, and it was a very, very beautiful volcanic island. But for some reason, Deborah and I really found ourselves quarreling a lot during the first few days of what really should have been a wonderful time. And of course, we initially personalized the arguments and said, oh, we're just not getting along. But then one day, as I was hiking down a mountain with Deborah, I had this epiphany. And I realized that the tension that we were experiencing was really not between us. It was a reaction to the honeymoon situation that we found ourselves in. At the time, the country of Portugal had anti-gay laws, and I realized it was the fear of what might happen if we were perceived to be on our honeymoon together that had us really so irritable and snapping at each other and short-tempered. The problem truly wasn't all just in my head. It wasn't an interpersonal problem between us, right? It was, frankly, the stress of oppression. That, that was the problem. It was the constant stress of hiding in plain sight that was affecting us. It was the sadness of no one to help us celebrate our union, or even to have the locals, coming up and offering to snap photos of the newlyweds. It was needing to be careful in a foreign land and not being able to display public affection on our honeymoon. It was being given a hotel room with two single beds, and every time housekeeping would come in the morning, they would take our single beds apart and push them to opposite sides of the room. Um, and we were always being given these two checks at the end of a meal in restaurants. And we were frequently misidentified as sisters by the locals. So this erasing of who we were was sort of in the very air, that we were breathing. It was all around us. But initially we internalized it and thought we were quarreling. But it wasn't that. We were anxious and we were scanning and we were double thinking and we were hypervigilant and we were very stressed. We were edgy. We were discontented. And all of this dawned on me as we walked down the mountain. And it was as if I had pulled the lens of a camera back. And I began to view our situation as arising from the environment that we were in. It was arising from the prejudice that we were navigating. It wasn't just between us. It wasn't just interpersonal. Widening the lens really helped take the focus off of the interpersonal and help us take into account the context and the situation and the oppression that we were immersed in. So widening that lens was very healing for me and Deborah on that day. And as we talked about it, we felt freer and much more grounded. And in the end, it really helped to name it. And that helped us to create an even greater bond between us. And in our time together today, what I want to explore with you is how, as mental health professionals, we can support marginalized people in managing the stress, the erasure, and in many cases, the traumatic stress that comes with living in a society which is sometimes unjust. So I would bet you that there are some people, including many that are in our Zoom room here today, who have experience with oppression. So I'm thinking perhaps you're a woman who loves to run, but often must plan your run to include staying out of the woods or other remote places in order to avoid the chance of being raped. Perhaps you think twice about using earbuds when you're out for a walk for fear of being harassed or attacked without warning. This is a very common example of the kind of planning and worry and stress that many women live with on a daily basis. I think we become so acclimated to it, we don't really even hardly think about it sometimes. Perhaps in our room today, here among us, we have folks who are Jewish. And that as a person who is Jewish, you carefully scan your place of worship in order to sit close to an exit at Shabbat services for fear that an anti-Semitic hate crime might occur that day. And this stress, this hypervigilance is part of what it's like to live under the oppressive shadow of anti-Semitism. In our room today, there are probably those of us who grew up in poverty and who know the stress and the real anxiety of showing up for the first day of school in hand-me-down clothes and not enough money for school lunch. This is the oppression, the subjugation, and the feeling less than, that goes with growing up in poverty in a country of abundance. I'm sure some of us in this room know the experience of body shaming and of fat oppression, where we have cultural expectations placed on us about being of a certain size, and because we don't meet those ideals, we often are bear the brunt of jokes and harassment and prejudice and shaming. I'm sure there are some of us in the room today who experience racism. It's another type of oppression, of course, that tends to marginalize and subjugate Black, Indigenous, and other people of color, while affording privilege to those of us who are white. And this is particularly true, and it's very important, of course, that we be aware of it in our field of mental health, that to be Black and to be receiving mental health services means that you're more likely to get diagnosed with schizophrenia when compared to white Americans. It also means that you're less likely to be diagnosed and treated for depression. It also means that you're more likely to receive higher doses of antipsychotic medications when we're compared to whites. And it means that you're more likely to be involuntarily committed and forcibly strained when compared to those of us who are white. Continuing on a bit, there are those of us in the room today who are older adults, and we face age prejudice and discrimination. So common examples of age prejudice and discrimination might include being denied promotions based on our age, assumptions about beauty and the pressure to act young or to look young, etc. And finally, and I could mention more, but I'll stop here, we have ableism. And maybe in our room today, some of us have a disability of one type or another. So a common form of oppression is ableism, which includes discrimination and prejudice against people with disabilities, including those of us with psychiatric disabilities. So just to get a feel for who we are in the room today, I'm going to bring up a QR code. And the question I'm going to ask you to think about for a second is, have you personally experienced oppression in your world, in your life? And here's a list of some of the ones that I've mentioned here, but I've also included the category other if I didn't land on the oppression you might. So what you do is you basically hold your camera up, your cell phone up, and you bring up the camera and you take, you get it in the viewer in focus, and then you go to the link you see on it, and it'll take you over to a poll. And in the poll, you can say your response. Here you can see the results. Yes, no, unsure. Yeah. You guys are pros at this, I'll tell you. Good job. Yeah, so many of you say that you have personally experienced depression. 32 of us, and one person is not sure. But no one's saying flat out no. So that's really interesting. And that was what I was hoping might happen with this particular opening for this workshop. I think when we think about oppression, we think about it as something that perhaps happens to other people. But I'm not sure that many of us feel like, oh, maybe sometimes it affects my life as well. So yeah, here we have uh, show that in this room, we know what this talk is going to be all about in some fashion, right? So my question is, and I'd like you to feel free to raise your hand and speak up. I think you'll be unmuted, or you could put your comments in the chat. Let's just spend a few minutes talking. And what helps you get through the hard times related to the oppression that you experience? I shared about a bit about myself.
All right, is this working?
Yes, I hear you.
Okay. Um, to be fair, I'm kind of going through a few things of my own here at work, and it's probably not a good time for me to answer this question.
Okay.
But thank you, though.
Okay.
Um, so I actually had my car break down the other day, uh, and I got into the tow truck cab with the driver, and this song that I've heard on the internet, uh, I didn't realize anyone actually listened to it, but it's basically about how people using they them pronouns are the death of America,
Ooh.
which I am visibly, obviously trans.
Okay.
Uh, and I had to ride an hour with that person uh, to get to where I needed my car towed to. Um,
Ooh.
and I basically just he mentioned it. He caught the song and was like, "Wow, I can't believe that song was playing." And I just laughed really hard, honestly. Like I just laughed a lot because objectively it was funny. It was very funny to me. Um, but going through this hour long ride in the dark with my broken car with this man who I've never met who clearly has issues with with my existence. um
Mm.
I really just spent the time. I feel like my like default sort of coping mechanism with those situations is just to be really talkative and very like exert a lot of control over the conversation that's happening. uh,
Uh-huh.
yeah, I'm extremely extroverted. I can easily carry on a conversation by myself. I don't need anybody's help. I can I can keep going for hours. So I just was very delicate and specific about the things that we discussed. And it actually became a pretty positive experience for him. Like we did talk about some political things that he didn't know about, but I was very careful to not be confrontational in any way and not mention any um, marginalized identities that I hold that aren't obvious. So like he was also like yelling about immigrants being criminals and stuff. I'm the first person in my family to be born here, but I'm white passing, so I just didn't comment on none of that. I just kind of dealt with the situation with what I knew he knew about me. Like obviously he knows I'm trans. It's very clear that I'm trans. I'm very visibly trans. Um, and I just tried to exert like social control to make sure that the conversation was never steered in a direction that might make him upset at me for existing, you know?
Wonderful. And I hope you charged him $50 for that important education. Right?
Yeah, no,
That
he
was good
charged
of you.
me $300.
Yeah, okay. Good on you. I loved it. Yep. Other thoughts?
Can you hear me?
Yes, Susan.
Okay. Um, I'm a woman, so I've certainly faced oppression because of that. But age prejudice. I'm almost 60 and I was looking for work um, about like 6 months ago, and I really faced a lot of that. So what helped me is I started following this fairy god boss kind of support group where there's a lot of people my age that were kind of facing the same thing. So it just kind of helped me to feel like I wasn't alone. Um, so yeah.
How wonderful. Power in numbers too, right? Just
Mm-hmm.
you're not alone. Yeah, yeah, beautiful. Anybody else want to share for a minute?
I'll
Sure, if
go
that's
ahead and
okay.
share.
Go ahead.
I want to say thank you to Q and Susan too for sharing. One of the things that has helped me get through the hard times related to oppression, it's really interesting hearing Q's experience because I use laughter a lot. I find that I do things to disarm people, and so that could be laughter, it could be comedy, and it's all in relation to how safe I feel and what spaces I'm in. I'm, of course, a Black female, and I also served in the military. So I was in some pretty stark spaces where I'm the only female or the only African American female in certain spaces. And so my coping, I guess, depends on the feeling of safety that I had and how much I felt that I needed to disarm people or be hidden, hide myself, kind of put on my own camouflage, or how much I felt that I really needed to put myself out there. And I think the older that I've gotten, I've been able to use my voice more, lean into those uncomfortable situations and spaces. So it's been an interesting journey in terms of how I've been able to cope with oppression throughout my life. One last thing I want to share is I'm finally writing this book that I have in me about my experiences with oppression. And it's kind of I want to say it's a gratitude to my younger self for being in certain spaces, oppressive spaces where I did not have the tools to use my voice, or did not have the support of people to help me through those hard times, those allies, I would say. Thank you for letting me share. I really appreciate this workshop.
Yes, thank you, Felicia. How wonderful. Good luck on that book. That's a big deal. Yeah. So let's just say that right here in our room here today, we have wounds from oppression, strategies for survival that are right here in the room with us. And that's probably going to be the case more or less wherever we go. That wounds from oppression, it's not the exception, it's rather more like the rule. And these wounds and the resilience that goes with surviving and thriving include things like anxiety and depression. And these are behavioral health words, and it's easy to pathologize them as opposed to widen the lens. Things like low self-esteem, hypervigilance, the whole thing about suspiciousness. And I know many of you work on early psychosis teams, coordinated specialty care teams with young folks diagnosed with early psychosis, and suspiciousness versus delusions, paranoia. I mean, it can get really, really a slippery slope. Of course, there's the double consciousness that W.E.B. Du Bois speaks of. This kind of, and so many, the number of you who spoke were saying it. I have to be present in the situation and reacting, and I have to be scoping it all at the same time so that I can figure out how I'm going to manage this situation and come out alive and safe. And of course, other issues like intergenerational trauma, chronic traumatic stress, disadvantage, shame. But also importantly, I think are medical conditions related to lifelong exposure to these stressors. And so I think the big message here is that I think more often than not, we need to assume that oppression and the wounds from oppression and the resilience that goes with living through it are in the room with the folks that we are working with, and that in no way whatsoever do we want to replicate oppressive dynamics when working with people in no matter what kind of service that we're offering, including in no matter what our training is, medical, psychology, social work, peer support. So we want to be part of the solution, and that's what gathers us here together today. We don't want to be a part of reenacting this stuff. So the question becomes, what really concretely not way up when things are all better in the future someday, but right now, starting today, starting tomorrow, some of these I'm sure you already do. Here are some of my thoughts on that. First of all, I think it becomes really important to take a look at our physical environment where we're working, our office. Maybe it's our car where we're working with people and transporting here and there. But we need to conduct an environmental scan and ask ourselves, can people that are coming to see me for services see themselves anywhere in this clinic? And this really came home to me one time when I was I was doing a presentation, and my friend Karis Myrick was there, and we weren't that well acquainted at the time. And she described to me later, coming into the room where my PowerPoint slides were way up on a big screen, and she said, she said, my gosh, she said, there are Black people, and this isn't a training on equity or anything, And she just said, "Wow, I can't believe they're just like people in the slides." And excuse me. Later, she said to me, Pat, that was so important for me to realize that I could see myself in the work that you were doing." Excuse me. So as we think that through a little bit, we need to ask, if we do this environmental scan, what are the magazines? What are the photographs, the pictures that are in the room? And how can people who are coming to see us see themselves there? We need to ask ourselves, when I come into the waiting area, is there a seat if I'm a large woman, that would actually, be for me, as opposed to those skinny little ass chairs with the big arms on them that are harder to fit in if you're a big person. So, or even if there's just chairs with no arms at all. So prepare a welcoming space and the idea that everyone's welcome here. I think the next thing that we can do is that we can prepare ourselves. And I think it's important that we learn about others' experience of oppression. So this is a practice that I've adopted in my life to good effect, and I want to share it with you. So by preparing ourselves, we can begin to understand others' experience and the subtleties of others' experience of oppression. So I may not have experienced racism, but I can expose myself to Toni Morrison, or, reading and understanding and watching films and poetry, and just trying to expose myself to others' experience. And this is a very powerful way, in my opinion, to open my heart. And I hope you might consider it too. So here's an example, recent example from my work around this. So I'm an editor of the personal accounts column for the journal Psychiatric Services. And recently we published an extraordinary personal account called Poverty by a woman named Cheryl Howe. And here's what just a little piece of what she wrote. She said, "Poverty is not just having a belly that aches for want of food. Poverty is when my siblings and I ate dog biscuits dipped in mayonnaise with absolute relish. Poverty is when I avoided the lunch line until the other kids were done and distracted by their food so that they could not see the color of my lunch tickets. Poverty is living in the projects where none of the kids I liked were allowed to visit me. Poverty is the pain of loneliness experienced when I slept crammed in one room with 6 siblings. Poverty is dreaming that I lived somewhere else, had a very different family that did not fight all the time, ate delicious food, and went on vacations to fantastic places I could only imagine. Poverty is not just waking up on Christmas with no gifts under the tree, but poverty is also knowing that Santa chooses your gifts on the basis of how good you are. Poverty is returning to school, hearing what everyone else received, and frantically making up stories about the fantastic things Santa gave to me. so that my classmates would not know how bad I must have been. Poverty was the abject humiliation I carried in a world that saw me as less than everyone else. A story like this, my friends, really just opened my heart. And you can find more stories like this particular personal account in these free open columns online at Psychiatric Services. Another thing that we can do is using my recovery library. Watching videos is a fantastic way to begin to widen our horizons and to begin to open our hearts to the experience of other people who experience oppression that we have not experienced. So Recovery Library, we have thousands of original 3-minute, 5-minute, 6-minute videos. And here's Tracy sharing an experience with her. And I find Tracy to be particularly powerful for opening my heart, is what she says.
Hi, my name is Tracy, and like many of you, my world has been flooded with stories and images of horrific injustice towards people of color. These stories aren't new to me. I've been hearing about them for decades, but the worldwide uprising has been like something I've never seen before. People are very vocal about wanting Black lives to matter, and people are very vocal about wanting Black people to get back in their place. So at 50 plus years old, I thought I had a good understanding of how oppression has shaped who I am and how I live and how I respond to certain things. I thought I had a strong handle on my feelings about racism. But these past few weeks have shown me that I really don't. I should note that I was raised by an African-American man who served in the Army in World War II. He fought for a country that did not fight for him, and he was proud to have done so. I should also note that my mother often shared stories of the death of her oldest brother. This was before I was born, but she believed that he had been killed by white people because he stood up for himself when he was being mistreated. His death was never investigated. It was ruled a suicide, and that was that. So my parents had the challenge of how to raise 3 Black children in America. And I feel like the messages were a mix of make sure you're standing up for yourself and just try a lot harder and keep your mouth shut and don't cause any trouble. I think as a result of that, I've become really good at just keeping things tucked away and trying to make sure everybody around me is feeling comfortable. So now what? What do I do with all of these feelings that have been surfacing over the past few weeks? Honestly, it's a work in progress. But I've decided to focus on 2 areas. One is finding my voice, and one is finding balance. For starters, I have joined up with other advocates for racial justice, and these are people who have very similar stories to mine, and they're teaching me how to find my voice, how to use my voice to affect positive change in the world. They are also teaching me how to forgive myself for not finding my voice many years ago. Secondly, I'm finding balance. Yeah, there's ugliness out there in the world, but there is also beauty. There is friendship. There is love. There are things that make me laugh. I am teaching myself that it's okay to embrace the beauty in the world. It's not the same as the tucking away that I had been doing. So I don't feel that embracing what's good means that I'm ignoring what's bad. So finding my voice and making sure I reflect on what's beautiful in the world. That's my personal medicine. In my line of work, I have to show up every day as a solid object, and so I have to make sure that I'm using my personal medicine to stay strong, well, and healthy I hope you find something that works for you too. Thanks.
So Tracy's an amazing person. I learned so much from her. So that's another way to begin to open our hearts and to prepare ourselves to know and that oppression is in the room. If I move on, and I could say that in addition to opening our hearts, we can explore our own unconscious biases so we don't replicate oppressive dynamics in our work with people. So let's take a minute just to explore what the heck I'm talking about here, to explore unconscious biases and how sometimes they play a role in how we relate to people that we're working with. So this important Nobel Prize winning psychologist, Daniel Kahneman, wrote an important book based on his research called Thinking Fast and Slow, Models of Human Cognition. And he argued that primarily we have kind of two systems, two ways of knowing. The first system, system two, really is about the part of our brain that is thoughtful and reflective, and we like to think that we reason things out. Q, I see your hand up. Please don't think me rude, but I'm going to be holding space at the end of the presentation where we'll have time to reflect, but I can't call on you now because I won't be able to get back on with what I'm doing. So I apologize for that. But we can definitely get on with it towards the end when we have another discussion period. So system two is this kind of slow, deliberate. This is what we were trained to do in our work, and it's thoughtful. And we like to think, as Homo sapiens, that we lived here. Then there's things happen, such as a wasp shows up. Are we going to really kind of, when that wasp shows up, sit there and kind of cogitate? Or are we going to react, right? And clearly, the vast majority of us are going to react. And this is the fast system of cognition. And it's a very fast information processing system, and it's based largely on our unconscious associations with things. So in system one, this part of our brain is just storing associations very automatically, and then rapidly, with almost no effort on our part, automatically it activates and applies these associations when we encounter something similar. And so this process of the system one, which is the fast system, really serves the need for efficiency. When the wasp appears, it is not time to really think about it. It is the time to react, and that is achieved through this efficient, fast association. Insect, sting, hurt, I'm out of here. No questions asked. So this is a powerful system, and the two work together. Now, clearly, when we are thinking about implicit biases that we may have as people and professionals working in the mental health sector, clearly, like you, I was trained. I know what my intent is when I meet a person, right? And I know that I am going to do my very best to treat this person as an individual, to withhold profiling them. This is my intent. This is my training. But it's only the tip of the iceberg. Below the tip of the iceberg, of course, are my implicit or automatic biases, the system one, this fast associational part of my brain where these quick associations happen largely unconsciously. I don't will them to happen most of the time. Most of the time, I just find myself there, right? And so as proof that this really is there, if we look at issues of implicit automatic bias in relation to behavioral health, there is, as I mentioned earlier, this underdiagnosis of mood disorder, overdiagnosis of schizophrenia, higher doses of antipsychotics when compared to whites, higher rates of restraint and seclusion, involuntary commitment. Importantly, even on just like an interpersonal level, right? Just things like a reduction in person-centered communication. And there are actually studies that show that we sometimes even have shorter appointments as white people working with people who, people of color. Shorter appointments, less empathy sometimes, and something called verbal dominance, where we kind of talk over the Black person in the room, the BIPOC individual in the room. So I know for me, this was really important to begin to kind of metabolize as a white person what this meant for me. And I am not immune to all of this stuff. And I felt really strongly about starting to get to work to do something about it. I don't like the idea of myself talking over people and not making space for their perceptions, for their truths. So what I began to do, and I would recommend for you might help, would be to check out the Harvard Implicit Association Test. Now, what I like about the Harvard Implicit Association Test, this is it does not collect any of your personal information, won't ask you for all of that stuff, but you can explore many different areas of this implicit unconscious bias. And it's kind of interesting. You take these various little association tests, and then you can take them for weight bias and age bias, transgender bias, race, religious biases, right? So I think that I would highly recommend this, and the link is in your handout. And this part of what is even more motivating for me around, not that I can ever totally undo all of my biases, but that I can work on it, right? And part of what has really helped me get motivated to do this work is hearing people I know, people I care about, talk about what it's like, what the lived experience of racial unconscious bias in health setting actually feels like, right? And so people have helped me understand it's harder to trust some white mental health professionals because of these biases. It can be more difficult to have confidence in the treatment and recommendations for treatment. And also, a lot more folks of color drop out. And here are some examples that people have shared with me. My therapist told me not to touch the computer when she left the room for a minute, and I think she doesn't trust me because I'm Black, and that makes it hard to trust her. Or this person, my peer specialist interrupts me and talks right over me. I feel disrespected. Why would I go see her again? I worked with my friend Stephanie Cologne on this whole issue of feeling profiled during psychiatric and medical appointments. And here's a little thing we made. Sometimes it's hard to trust a white doctor. Please welcome my friend Stephanie Cologne.
Hi, my name is Stephanie Cologne. I want to share a story with you. One time I needed medical attention from a doctor. My mother accompanied me to the clinic, and I was assigned to see a white doctor. My mother waited for me outside the exam room as I talked with the doctor. I was explaining the symptoms I was experiencing and mentioned that I had lived and traveled outside the United States for the past 6 years. The doctor told me to wait a minute, and she stepped outside to talk with my mom. I heard the doctor say, "Your daughter is delusional. She is saying she is a world traveler. There's no way a woman on Medicaid can do that." I knew at the moment that doctor was not seeing me as a unique individual. Instead, she had put me in a box and was seeing me through the lens of her racial bias.
So again, another experience, another example of how this bias can, really hurt people and keep people from. Sometimes it's hard getting the care that's right for them. So clearly, our job is not to help people get adjusted to injustice. That's not the thing. And of course, it was the Reverend Dr. Martin Luther King who really impressed that point on us way, way back. I believe it was 1967. He addressed the American Psychological Association in Washington, D.C. With these words. And let's not get adjusted to injustice, right? Let's continue to remain maladjusted and continue to do our best to be there for the individual that we are meeting with. So what else can we do concretely? Well, one of the things that I find to be very helpful, and I've also read can be experienced as very helpful, is to build partnership with people. And instead of talking about I and you and you and you need to and I, let's instead talk about we and us, and that can build a sense of partnership, right? So since this medication did not work out, our best course of action might be to, or hey, if we do this decisional balance worksheet before the appointment, it might help us get the results that are going to be best for you. So build partnership, person-centered partnership, shared decision-making, use we and us instead of you. Secondly, we can learn to use tools that address oppression. And there are tools that are out there that we can use. And so here's Harry and Fatima. And they have a peer specialist relationship. Harry is a peer specialist. Fatima is struggling with voices, with hypervigilance, and with trouble sleeping. And she's concerned about anti-Muslim hate and discrimination. So Harry, the peer specialist, asks if Fatima would be interested in exploring how oppression might be affecting her. So together they decide to get a small group started. And they decide to use a mutual aid peer-to-peer support group for oppression and mental health challenges. This is published by the Icarus Project, and it's a great and free resource that the Icarus Project back in the day gave me permission to pass along. And so you have this in your handouts for this workshop. It has 4 challenges or 4 sections in it, and it walks us through asking each other, what is oppression? How do we experience it? How do we cope with it? And how to address it in our communities to achieve collective liberation. Like all stuff that the Icarus Project does, it's really almost like a mini workbook where you can fill it in the old analog way and share with one another. And we learn together about oppression and how to manage it. Another tool that we can work with is, again, in the Recovery Library, which many of you have direct access to. I have what are called personal medicine cards. So personal medicine are the things I do to be well. It's the idea that I reclaim the word medicine, and I say that, hey, laughter, love, meaning, and purpose, the things I do can change my biochemistry. So for many of us, finding the right balance or finding the pathway into the life we want means finding the balance between the pill medicine I may take and the personal medicine I have discovered that comes from the healer within me. And so here's an example. There are 18 categories of various challenges that people experience, as you can see here, and that each of these represents a set of cards. So there's harm reduction cards, and there's troublesome beliefs, personal medicine for troublesome beliefs, etc. And each contains about 20 cards in that category. And again, these cards really just reflect common challenges. So here's Fantasia's story with personal medicine card. She says she had been struggling with anorexia for a while, but therapy really helped, and she started eating again. However, once she started eating again, she also began to self-injure instead of starving herself. And at that point, her therapist introduced her to personal medicine. And Fantasia had never experienced that. So one of the things we do in the practice of personal medicine is we look at, these are self-harm personal medicine cards. And so we review these cards with somebody and ask them, is there any card that might, speak to you? And Fantasia said, yeah, I'm interested in this oppression card. And please note that the cards are in English. They're also in Spanish, and they're form fillable and can be used in telehealth too. Okay, so she's interested in a particular card called the oppression card within the self-harm category. And on the front of the card, it says, name the oppression contributing to my urge to self-harm. And it says racism, homophobia, poverty, sexism, and other forms of oppression can lead to deep feelings of shame and self-loathing. Harming ourselves is not the answer. Naming the oppression we experience, how it affects us, and joining with others to fight it can help. And then on the back of the card, right, we can put what is the oppression I experience? Well, she says, I've been culture bombed with the message that I'm never thin enough. Then the card asks her to personalize that. How does that affect you? I've struggled my whole life, right, with these feelings because of my weight, and I'm over it. I'm going to fight to end the shaming of women's bodies. So she's considering joining the body positive activism group at the Women's Center. And she finds over a period of weeks that this is actually working for her. It reminds her, me, that I'm not less than. I'm part of an amazing community now, right? So again, this is a great example of widening the lens. You have a copy of this personal medicine card in English and in Spanish, okay? So back to personal medicine cards, we actually have an entire category of them on just oppression itself. And this is a hugely popular category of personal medicine cards within this challenge area. Anybody who's experiencing oppression is welcome to check out these cards. And this is probably, of all the oppression personal medicine cards, this is a big fan favorite, I'll tell you. Remind myself I'm having a sane reaction to an insane situation. It's normal to feel anxious, paranoid, depressed, scared, worried, angry, to have trouble sleeping and concentrating when oppression touches our lives. Often oppression is the problem, not mental illness. And then people once again are asked to personalize this card in ways that make sense for them, right? So again, you have a copy of this personal medicine card if you're interested in using it with people that you perhaps are working with. Let's do another resource in Recovery Library. This is Luke. And Luke is having a lot of trouble getting the medical care that's right for him, okay? And so this is a common form of prejudice with rather disastrous outcomes if allowed to persist. It can be hard to get evidence-based medical treatment that's right for us when the medical care team knows about our diagnosis, when they know about what antipsychotics or whatever meds we may take. So the phenomena is called diagnostic overshadowing. And it occurs in all types of medical settings. And it refers to the tendency of healthcare professionals to misattribute symptoms of physical illness to an existing mental health condition rather than considering them as separate or co-occurring issues. And this can lead to a lot of unwanted consequences, such as delayed diagnoses or completely missed diagnoses of real physical ailments. And that can result in poor health outcome for us and potentially harm for those of us with mental health conditions. So, we know the data. We know that in America, those of us diagnosed with a serious mental illness are dying on average 20 to 30 years younger than the general non-diagnosed population. This is part of the reason we're dying young. Because when we show up in the emergency room, we're not getting the care that's right for us. We are told too often, look, it's all in your head. This complaint is all in your head. So one of the most used resources we've developed here in my company and it's in Recovery Library, and today you have a copy of it as well. It's called It's Not All in My Head Worksheet. This is a hugely important thing that we can do in working with people who might be experiencing the implicit bias that occurs despite the best of intentions of medical practitioners, right? Once we know that I have a diagnosis of mental illness or that I take psych meds, it could be difficult for me to feel confident that I'm getting the treatment that's right for me and what ails me. So my message to people is prepare, prepare, prepare for that meeting, for that encounter, right? And so what we can do in preparing is follow this worksheet. What's the pain or the symptom that I'm experiencing? What activities does it interfere with? On a rating scale, how would I rate it? What do other people observe, if anything, when I'm having this pain or this symptom? What do they observe? In other words, get that outside perspective. When did I first notice it? When does it happen? When doesn't it happen? What, if anything, helps? What makes it worse? And then a plan for sharing this with my doctor. I'll bet there are plenty of people in the room here today who have had the experience of diagnostic overshadowing and know how frustrating it can be and how difficult it can be to navigate it. This worksheet really works. You take it to your psychiatric care provider, to your internist, to your nurse practitioner at your annual physical. If you have a complaint, prepare and hand this worksheet. And part of what occurs is it breaks up that automatic bias. And it's like, oh, this person has prepared for this appointment and it really cares that I understand what it is that's going on with them. And I've gotten great feedback from people about how this particular worksheet helps. You have it again in English and Spanish. It's form fillable, and you can use it during telehealth visits. Okay, and Q, this is the next and final discussion time. We've got some time. Let's talk. What are your next steps in providing care that's right for the individual? Some things I've suggested here: read first-person accounts, take the Harvard Implicit Association test to learn our biases, create partnership with people, use lots of resources that I've shared today. Other ideas that you have. Going to open the floor. Please feel free to comment in the chat or to raise your hand and that kind of thing. Yeah, I see your hand, Q.
Yeah, I just wanted to mention, and I hope that if there's anyone on the call who doesn't have like a visible marginalized identity, please listen to this. Don't just leave yet. But I've actually experienced bias that was sort of transferred from a client to me. I was thrown out of a business because I had been helping a client, and the staff of that business, after the client left, they perceived me as homeless because they knew that my client was homeless, and they tried to throw me out of their store into a brainstorm. I was not visibly trans at the time. I was cis passing. I'm white passing. But I just wanted to mention that experience because, like, if you're not actively wearing a lanyard, and even maybe if you are, it is possible and that anyone really could experience bias just for associating with our clients, unfortunately.
Yeah. Yeah. I think that happens a fair amount sometimes too. And I remember a peer specialist telling me a story. He was going into a hospital setting, and he works with people who are patients on the inpatient unit upstairs, and you have to take an elevator up. And staff, of which he was a staff person in the hospital, he was a paid peer specialist, did not have to go through the metal detector, but they made an exception for him because he was diagnosed with a serious mental illness and made him keep going through the, yeah, it's really something. Other thoughts from people? Anything you're going to do differently? Other things that you would recommend that I didn't touch on today? Hi, Sonia.
Hi, Pat. I was seeing a question from the Q&A from earlier that said, what do you do when the oppressor is also someone with a marginalized identity? Horizontal hostility or lateral oppression?
I don't know. I have a terrible, one of the best things I've learned to do is to act perplexed and to say, I don't understand what you mean, or I don't understand what you're implying or saying. Help me make it clear. In other words, I'm asking the person sort of to raise up their comment, their gesture, and to raise it up to a level of articulate intelligibility is what a professor at graduate school would call it. Speak it, bring it right up to the surface. And that serves me well a lot of the times when I'm unclear about, I know this is weird, this hurt, I feel slighted, I feel put down, I'm not sure what happened, and just politely ask the person that I'm not following you, please explain. And it's a very powerful way, particularly in instances of microaggressions. And let me just give a simple example. My daughter, we would go to her school when she was little, and at the parents barbecue night or whatever it might be, and you would be there with bells on to see the little one and meet her class and teachers and stuff. And one parent walked up to me and said, now you two, me and Deborah, you two must be Cheyenne's, what do you call it? He said, parents? And she was like, oh yes, of course, your parents. So it's just an example of forcing the situation to get clearer. So yeah. Thank you, Sonia, for reading that. Other thoughts?
We have another question here. Let's see, I got to go back up here. So first of all, they wanted to thank you for your wisdom and the information and willingness to share it. Can you comment on some of the intricacies in keeping a lens that includes accounting for oppression when working with someone with serious mental illness that includes anosognosia?
Yeah. So
Okay.
I am not sure or convinced that the prevalence of anosognosia is as widespread as sometimes claimed. I know that we get taught it at the graduate level, and for those unfamiliar with the term anosognosia, it basically refers to the idea of kind of like a brain blindness, that the brain doesn't understand or see or have insight into the fact that one is, for instance, psychotic, or and so I think that I don't think it's that widespread. I think what does happen a lot is that folks that we're working with very much disagree with us or have very different understandings and stories and narratives to make sense of the experience that they're having. So like any good clinical or peer work, the place to start is really trying to get into that person's shoes and try to understand where they are coming from. And to also, the most important thing we can understand is, even if you don't think you're unwell or that it's a biologically based brain disease, there may be some areas in which we can find common ground. So there are probably some areas where what I can do as a clinician, as a peer specialist, is to say, okay, we're not going to get very far today talking about your illness, but let's find some place. Oh, you're having trouble sleeping. That we can share. And then sometimes having trouble sleeping can also involve, for instance, feeling like they're out to get me, and that sometimes maybe a particular segment of society is out to get you. And talking about how to create that island of safety, that space where I can feel safe. And that becomes a shared project with the individual. So I think it is very much possible to be able to loop it in, that some of the fear, the anxiety, the uncertainty, the terror that people might be experiencing can very much be based in the situation they find themselves in, which can include oppression, I think. I think the teasing it out becomes less, I get less worried about causal and what accounts for it, and more intrigued with the question of how do we find common ground here together, because we need to shift the focus from what's the matter with you to what matters to you. And if I understand that getting sleep matters to you, we're off and running. We can work with that. So that I don't mean to be flippant in my response, because sometimes it can be your mouth kind of drops open and you say, you don't think this might have something to do with being unwell, and people go, no. And it can be amazing. But I've met so many people with diabetes, type 2 diabetes, who are like, nah, nothing. It's nothing. I got high sugars, but nothing. So there's a lack of insight. I can measure that. So it's a thing we humans do sometimes. Yeah. But if I find out that what you want to do is you want to be there for your grandchildren, so we're not going to, talk about diabetes. We're going to talk about you and your grandkids and how we're going to keep you around for them. Yeah.
We have another one. The question is, have you ever seen the worksheet, It's Not All in My Head, used or whether it's been beneficial for those who have other pain and or medical issues?
I can't say that I have.
Okay.
I've created it specifically, honestly, because my own experiences of the kind of bias you encounter in medical settings, the diagnostic overshadowing. And so I've not known of anyone who's tried it out. If you do try it out or you have some ideas there, I'd very much like to hear them.
Yeah, we had one person who had that thought, so it'll be good for them to try that out.
Please, yeah. All right. Well, it's been a joy to have this time with you. I really am grateful to the Washington Healthcare Authority for having me and sharing this time with you. And I've learned some things from you, and I do appreciate that all. So thank you very much, and see you again, I hope. Take care.
Thank you, Dr. Deegan.
Yep.